Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today we have a discussion on a recent article that was published in the Journal of Palliative Medicine, which is titled "The Impact of Palliative Care Clinical Pharmacists in an Inpatient Care Setting on Total Health Care Expenditures." And we are so lucky and fortunate today to have two of the authors with us. So first, we have Dr. Robin Hill. She completed her PharmD from the University of Texas, followed by a residency at Emory Healthcare in Atlanta, and then a 2-year pharmacotherapy primary care residency at the University of Texas Health Science Center in San Antonio. She's worked in her current position as a clinical pharmacy specialist at Kaiser Permanente in Denver since 2005, where she supports the outpatient and inpatient palliative care teams. Welcome, Robin.
Thank you.
And second, we have Dr. Liz Willett. She completed her PharmD at the University of Mississippi. She completed her PGY2 in ambulatory care with Kaiser Permanente, Colorado, where she had the opportunity to capitalize on one of her areas of clinical interest, which is pain management and palliative care. And in 2015, she joined the clinical pharmacy specialist team at Kaiser Permanente, Colorado, where she provides pharmacy support to inpatient and clinic-based palliative care teams and serves as a core faculty member for the Palliative Medicine Physician Fellowship. Welcome, Liz.
I'm glad to be here.
So our format for today is going to be two parts. Robin, Liz, and I have agreed to just a couple of questions, and then maybe we'll have a minute or two at the end if the audience has anything for today. So we will just jump right into it then. So, we've been talking how medicine is many things and it is a business. And so palliative care teams, pharmacists, everyone needs to make a pitch of how we're contributing to that business model. So for our first question, when we were reading your article, we were struck that your clinical pharmacy specialist service started in 2005, which seemingly was before most of the supporting literature. So two parts. Number one is, how did you initially get this program accepted from a business model perspective? And then number two, looking back almost 18 years later, how has it changed about how you're continuing to sell this, how you're continuing to pitch this to administration?
Sure. So I will say that I was the result of the initial pitch in 2005. So I came on board then, and they were looking for a pharmacist that had some clinical experience, not necessarily in palliative care, because there weren't a lot of pharmacists that had experience in this specialty. But it was a different time, and the palliative care department here was just starting. We were lucky to get a couple of national leaders who were physicians, and then there were a lot of other physicians coming from different departments, such as primary care, who had worked with clinical pharmacy at the time and were big advocates for having clinical pharmacy on board. There was a lot of involvement in the primary care department with clinical pharmacy, and there was more literature supporting clinical pharmacy in a primary care setting than specifically in palliative care. So our pharmacy director at the time was very bought into expanding services and wanted to expand services in specialty departments, including palliative care. I will say, over time, things that we've had to do or continue to do to document a return on investment or some cost savings are just individual patient level documentation of interventions that we've done and any cost savings that resulted from the interventions that we've done. And then there have been initiatives over time, both on the inpatient and as well as on the outpatient basis as well. It could be anything from, working on making sure that we're using preferred long-acting pain medications to doing our best to avoid some of the more expensive brand name medications for opioid-induced constipation, for example, or back in the day before pregabalin was generic, dose consolidation made a big difference in the monthly cost for those prescriptions. So using our ability to do some of those initiatives and tracking those costs over time allowed us to do some documentation of return on investment. Obviously, we're not just about cost. I mean, we do want to,
Of course.
document some quality initiatives as well. So, for patients that are admitted with COPD exacerbations, are they on the right inhalers? Safety is a big thing in palliative care and in the opioid world right now. So, we've led several initiatives around Narcan prescribing and making sure that anyone on high dose opioids, has a Narcan prescription available, and has some education around that. I think the part of our issue is that, we don't have a lot of new drugs popping into palliative care all the time like we do in other specialty departments. So our colleagues in GI and oncology who have, this constant influx of new biologics or new immunotherapy, they have these high cost drugs that they can do some type of, pathway for, or intervention to make sure that they're used in the right patients. And, we don't have that. It's, it's definitely a challenge. And how do you justify, continued resources from a pharmacy standpoint? So, that was part of the reason we did this study. I mean, thankfully it wasn't you do this study and it comes out the way we want, or you lose your jobs. But, it was our manager's idea to see, what kind of difference we could document, or what kind of outcomes we could see. And honestly, we were advised by one physician, don't do that study, don't do it, because we're involved as a team, as part of the team, so we didn't know how it was going to come out. Another thing that I did want to mention is that there is a national initiative in Kaiser Permanente as a whole, not just in Colorado, but in California and in the other regions, looking at care for our sickest members. And so we are expected to continue to expand the number of patients that palliative care sees on both the outpatient and the inpatient settings. And so, we've made a pitch to say, this is important nationally. This is an overall organization goal. And so we need to be a part of that. And we need to have the resources to be able to do that, so that we are available when those members get sick and when, they have symptoms that could potentially be impacted by drug therapy.
Lovely. I was sitting down with some of our oncology pharmacists who would love to work and transition into being a palliative care clinical pharmacy specialist. And so we were looking at your paper, and one of the question marks that came up is comparing your healthcare system to our healthcare system, because you referenced something called a closed system. I know here in Milwaukee, patients have access to a handful of different organizations, and they seek care kind of all over the place. Can you just tell us a little bit more about that? What's this closed system? Can patients get care elsewhere?
Yeah, so I first just want to clarify that, yes, our patients can access emergency care at any facility. They can be seen, but there are incentives and things that keep them coming to our contracted hospitals. Kaiser Permanente Colorado does not own their own hospitals. We contract with certain hospitals that are our preferred places for our members or patients to go. So there are a lot of advantages. And with that closed system, those patients going to those preferred hospitals, because we do have an integrated care delivery system. Kaiser Permanente has an HMO model type of care, which definitely impacts, overall care and this study. And as far as a closed system with palliative care, we have palliative care in every setting. So we have teams in the inpatient setting, teams in the clinic-based setting, teams in the home-based setting. So these patients are on a continuum of care. They don't get discharged to a different system. They get discharged to clinic-based palliative care. So if you're following a patient in the hospital and say I've made a lot of changes with their medications, I know that they're going to get a nurse call from our clinic, from a nurse that I work with. Or that I know. So it is that system of having access to the medical chart, but also being kind of all on a bigger palliative care team across those different settings. The other thing that happens that I think is really special and great for our patients and for providers in different disciplines is that you can see patients in different settings. So we do have palliative care doctors who both do clinic and inpatient, and then as clinical pharmacy specialists, we're in the different settings too. So we might be caring for a patient that we've seen in clinic, and then we see them in the hospital, or we're able to keep them out of the hospital because we're able to provide a higher level of care in the clinic setting because we have the support to keep them at home, which is, where they want to be, obviously. Yeah. Most people want to be.
You guys have sort of the perfect milieu in order to make this a bit more feasible. Yeah, that's wonderful. Makes it a little harder for us to apply, but something to aspire to, perhaps.
Sorry, one other thing that I want to point out too is that the other thing with the study, when you look at our numbers, because it is a closed system, all of that money, the money that we've saved really includes everything. So it's not just looking at inpatient dollars saved, it's looking at overall cost of care, which might not be captured by other systems, but is captured maybe by an insurer, if that makes sense. Yeah. So it's just a different, way of looking at cost savings.
Sure. So during your rollout for the palliative care clinical pharmacy specialist service, what were some of the barriers that us as clinicians posed to accepting pharmacy involvement? Was there resistance from who?
So Robin and I talked about this question a lot. And we've been really lucky. She's been obviously with this team since 2005. We had physicians come to pharmacy leadership and say, please, we want a pharmacist on the team. We want this support so we can focus on getting strong at doing these conversations, and they can support us with the clinical pharmacy knowledge as we're kind of getting up to speed. And now we're doing obviously more complex, nuanced work. But we're very fortunate to work with a great team. We have a specific physician that's kind of been a leader in our department who refers to us as, hey, I want you to talk to my pharmacy doctor. I want you to talk to the oncologist directly about this because they need to hear it from my pharmacy doctor. And obviously we're pharmacy doctors. We have a doctor of pharmacy degree. But changing that language sets people up for success, and then having your palliative care physician be really bought in really helps set the stage with other professions and other physicians. I don't think either of us really felt pushback from really any other specialty or internal medicine in the hospital. And I think part of that too is because across the system, a lot of doctors are used to having clinical pharmacists on the team. So they're used to that interaction. So that could be it too. But I think a lot of it has to do with just how the interdisciplinary team works immediately and supports each other and looks to each other for that discipline to be the expert in that specific content. And I think that's how we function on a high level with that, which is really wonderful. I think barriers, we have hit other barriers, which more have to do with, certain contract hospitals prefer, certain medications and coordinating that and making sure that physicians understand and have clear expectations, or hitting barriers when we are trying to discharge patients on PCAs to either home-based or to hospice, and coordinating those things. And there's more barriers involved in just accessing and knowing what's available and that kind of thing versus actually having pushback from our involvement or pushback on our recommendations.
That's great. Length of stay, hot topic these days. And we see that in your paper, involving an inpatient clinical pharmacy specialist increases the at least initial length of stay. And we worry, looking at that piece just in isolation, maybe some barrier in some way. So two things. So number one, tell us a little bit more about the increased length of stay and how it was overcome by the total cost. And then number two.
I mean, I think we were, that's the one thing I'd love to go into this paper and change it.
Change.
The outcome had come out just a little bit differently in terms of that. I think what we're hoping is that assuming or have a good feeling about is that we feel like that we were likely consulted on patients that probably had a little bit bigger of a symptom burden that took a little bit longer to handle. And that by spending that extra day, that we were able to come up with a good plan that was setting them up for success down the road. And that's what we saw in terms of subsequent hospitalizations were lower in the pharmacist group versus the non-pharmacist group, as well as urgent care visits as well. And so, our feeling is that we took a little bit of more time to fine tune that, and then we had better outcomes later. And then, the other thing is, and depending on your reimbursement model, that may be a big deal or a bigger deal. From our standpoint, we were looking at our, overall dollars utilized. And since we were able to show a lower expenditures on a daily basis in the pharmacist group, that seemed really, from our standpoint, that trumped the increase in length of stay. If we're able to decrease cost savings overall, that's the better outcome than did they spend one more day in the hospital. But totally get that depending on your stakeholders and your employer and your system, that length of stay could definitely be a barrier in applying this.
Well, and another pitch for involving palliative care earlier. Like if they had involved you guys or the whole team, from day 1, 2, or 3, instead of involving you the day before discharge, perhaps that would dissolve entirely. Maybe. All right. One more question before we open it up to the audience. So if anybody here has any questions, just use the raise hand function or put something in the chat. So our last question is, and I'd just like to ask everybody the same question. We always find that authors, maybe they have discoveries that just don't make it into the publication. Was there anything that you found that isn't in there that you want to share with us?
I don't know that this is a discovery, but we've thought a lot about this. So our service has been around for 18 years, which we keep talking about. But as you guys know that work on a multidisciplinary team or an interdisciplinary team, you get a lot of information from the time that you do spend with a social worker, with a chaplain, with a pharmacist. So even though at these contracted hospitals, we weren't physically on site and we didn't consult directly on that patient, I still think they probably had an impact from us because the people that were taking care of, the professionals that were taking care of these patients have worked with pharmacists for many years and have a skill set and have taken away knowledge from having time and clinical work with a pharmacist. So I think that's just an important thing to note and could be something to point out when you are using this study that, hey, that you have an impact even when you're not directly involved, when you've worked on a team, when you've had that clinical specialist on your team and worked with them directly and with other patients, because you take things away from other disciplines that you've worked with. So I think you could see a bigger impact or difference between, say, a different hospital system that had a different, physician and palliative care team that perhaps never worked with a pharmacist.
Yeah. And a big pitch that every multidisciplinary palliative care team should have at least 5 members.
Yes.
Right? Pharmacists should be
so much from each other, and we take it away and can apply it. It makes us all better.
Yeah.
I think that we keep coming back to that continuum of care, and that's such a big deal too. We wanted to not bias the outcomes of this study by including patients that had been seen on the outpatient palliative care side as well. But it makes such a difference in the individual patient's care. When we're able to, I get a call from the inpatient physician saying, hey, we just admitted Mr. So-and-so, and I already know who that is, and I already know why they're on the funky drug regimen that they're on, and can go from there versus having to start from scratch. And being involved across the board is just so helpful. And I think the other thing that I just wanted to kind of touch on is how things have changed over time. We talked about how, in 2005, there was, a whole lot less palliative care training out there, and, our roles have changed. When back in that day, when we were having a lot more kind of more basic conversations about drug therapy, and the depth of fellowship training has really changed, and now we get people who are really prepared to come out and already have ideas and patterns of how they want to address things. And we don't get the easy questions anymore. We get the third or fourth line drug therapy, and the patient that's not tolerating anything. It's not it's harder stuff, so which is good and fun. Makes for a more challenging day, but a more rewarding practice. But it's really nice to be a part of more elevated care as we've gone on, and can really feed off of each other and learn from each other over time.
Well, lovely. I really appreciate your time today, Robin and Liz. And we don't have any additional questions because you've done such a wonderful job of explaining it, and we appreciate your paper. And thank you for being here.
Thanks so much for inviting us.
Thank you.
Absolutely. Have a great weekend, everybody.
Thanks.
Bye.